Hello, is my screen visible? Hello.
No, sir, it's not visible.
Now?
Yes, we can see it now.
Okay, welcome everyone. I am Dr. Koushik Tripathy. So I am a retina consultant at ASGI Hospital, Kolkata. So I thank Professor Muthuswamy sir for giving me this opportunity to present. And I am also thankful to the faculty members of MVUPGO, including Vijaya ma'am, Gata ma'am, and other faculty members and the members of MVUPGO from whom I learn every day. So this is a mock exam, and the time for each candidate will be 4 minutes. Do not prompt. If you are not the candidate, please do not talk. I am making all people co-host so that if other people are joining, then you can actually add them and also mute them if they are not speaking. So who will volunteer for this? So basically, if when you are at least when you are presenting, you can switch on your camera so that we can see your face and your expressions, because you should not look worried or you should not be in a hurry. This is an exam and you have to be calm and composed. And so this is just a relaxed mock exam. You should need not worry. So we are just here to learn from each other. Do not hurry. If you do not know, then say do not, I do not know. That is the best answer. Do not say that I think this, I think that might be this. What you think doesn't matter. So do not say that. And examiner wants to know what you will do, not what you have read in the book. So definitely you should not miss something which is vision threatening or life threatening, or you should not do something which can threaten or endanger the patient. So obviously examiner should be convinced that they are in safe hands. So do not say that I am a cornea consultant, I'll refer the patient to retina colleague. No, you say that I'll collaborate with the retina colleague, and you should know what the retina colleague will do. So you have to practice history taking, evaluation, management of all patients, and practice like specifically exam. If you are like weak in oculoplasty, examine all patients for ptosis, proptosis, and keep a note of that and try to discuss or show it to a oculoplasty subspecialist. And if you have any question, you can add your question to the Zoom chat. So who will volunteer today? First volunteer, Dr. 2D. You have joined first, so you'll be volunteering first. Okay. Dr. 2D. If somebody doesn't volunteer, I'll just remove them from the chat, because this is my time and I will not waste time on people who are not volunteering. Yes, Dr.
Yes,
2D?
sir.
Okay.
Yes, sir.
Yes. So this is a patient who has this uh, the he has dimness of vision in this eye. What do you see and what is the diagnosis here?
The fundus image of the left eye. In,
Left eye. What does it show?
uh, it shows the subretinal fluid at the macula.
Okay.
Collection of subretinal fluid in the macula. There's a blurring of margin of this at in the temporal border, along with the
What could be the diagnosis here?
by and differential diagnosis for three first three central serous choroidal retinopathy.
What? Central serous choroidal.
Said
Okay. Okay. Any other differential diagnosis here?
because it is there is the temporal margin of the optic disc is also connected. Um, optic optic
Optic. What is it called? So there is this thing, na, temporarily there is something.
Optic disc maculopathy.
Okay, optic disc. So what do you expect in the OCT? What is
The
the name of the
OCT,
syndrome? Do you know the name of the syndrome? If there is optic disc pit and there is maculopathy, what is the name of the syndrome?
no,
Okay, it's okay.
I can't remember it now.
What do you expect in the OCT? If I do OCT macula, what can I see?
In the OCT macula, in the case of CSCR and also optic disc maculopathy, you see
No,
uh,
is CSCR and optic disc pit maculopathy same or something else? They are different.
no, both are different only. I'm telling
So
you
if
in
it
the
is
case
optic
of
disc pit maculopathy, then what OCT feature do you expect?
there will be a sensory your retinal detachment, which is connected to the optic disc, which is continuous in the optic disc.
রেখে দাও না no there will be what did you say subretinal fluid and
It can be traced. We can trace it till up till the optic disc,
no it can
which
be
is
connected with the optic disc. There is subretinal fluid there may be. What other feature can you see other than subretinal fluid? So I think we have crossed 4 minutes. Any other candidate, can they say what is the other finding? There can be subretinal fluid. Any other candidate, what is the OCT finding along with subretinal fluid? Dr. Temina?
Yes, sir.
Neurosensory.
Basically,
Yes.
multiple level retinoschisis can be there. There can be intraretinal like cytic cavities. So please read about this optic disc pit maculopathy, and this is not CSCR because this thing is connected to the optic disc pit. There is pit. In CSCR, it will be the subretinal fluid will be separate from the disc. So who will be the next candidate? Who will volunteer for this?
Sir, I'll take it.
Okay, please, Dr. Today you did not introduce. Please, where are you practicing?
I'm doctor today. I'm practicing in UAE. I'm currently practicing in Ajman.
Okay, in comprehensive. What is your specialty?
Yes, comprehension.
Okay, take it. Next, you may please
Yes,
say. Dr. Mariam, yes.
yes. I'm Mariam Hussain, and I'm in Karachi, Pakistan. I'm also comprehensive, no specialty.
Okay. So this patient has dimness of vision in both the eyes, 40-year-old male. So what do you see?
Okay. So there is media opacity. The view is quite hazy. I can see the disc. I am the disc margins appear blurry, but I think that is because of the media opacity. The blood vessels
Can
in
media opacity create blurry disc? So do not speak anything which you do not know. Media haze cannot cause the disc to be margin to be blurred.
okay.
Disc margin needs
So
to be blurred due to some disease in the disc margin. Only media opacity cannot cause disc margin blurring.
okay.
This was a wrong statement, and do not tell any wrong statement during such during exam. Okay, what do you see otherwise?
Okay. So the vascular arcades, the nasal vascular arcades seem to be, I can't visualize them. And
Which eye is this? Which eye is this?
this is the left eye.
Okay, what do you see in the macula?
The macula has exudates
Which exudate?
and
Which exudates?
center involving.
No, which exudates? What are the types of exudates you know of in retina?
Discrete, the edges are discrete, so I think
No.
these are hard
Okay.
exudates.
What is the other type of exudate?
Soft ones.
Okay. What is the hard exudates are composed of what?
Uh, After a long-standing macular edema, the
No. What is hard exudate composed of? What
mm,
does it contain?
I can't remember.
Okay. And what is the histopathology of photoneural spot?
Those are neuronal debris at the retinal nerve fiber layer, axonal debris.
Okay. What do you see in the lower part? Outside the arcade, there is some label-like thing.
Yes.
What is that?
So
This.
yes, yes,
What is this?
there is hemorrhage, and the hemorrhage is showing a fluid
What
level.
kind?
So yes, so it appears to be pre-retinal because of the fluid level.
Okay. So considering this, what is your diagnosis?
Proliferative retinopathy with vitreous hemorrhage.
Proliferative what retinopathy? If the
It
patient is
looks it looks diabetic to me.
okay. Your time is up, but you did good. Please do not tell like anything you do not know, do not tell.
Right.
Because in trouble, read about how to manage proliferative retinopathy, how to manage coexisting DME and PDR. Who will volunteer next?
Yes, sir. I'm Dr. Heba
Dr.
Mansour.
Heba. Okay, Dr. Heba. So this is some imaging has been done. Just discuss what do you see. Dr. Heba, please you introduce yourself also.
Yeah, I'm Dr. Heba Mansour from Egypt. I'm general ophthalmologist. I'm
Okay.
appearing to the exam next June in Cairo.
Okay, please. What do you
This
see?
is a fluorescein photo, fundus fluorescein photo for the right eye, and the latest stage, showing
What is this 4.07? In the upper right corner, it is written up 4.07. What is that? 4.07.
This is the time after injection of fluorescein.
What time? What does it mean?
It means that
4 hour 7 minutes or what? This time?
4 minutes and 7 seconds.
Okay. Then what do you
Yeah.
see in this photo?
So I can see multiple areas of hyperfluorescence with multiple areas of hyperfluorescence, and also I can see area of increase or enhancement fluorescence temporally, inferior temporally.
Okay. Then what is it?
And
If I say this eye is the other eye of the previous patient, then what would your diagnosis be?
I can diabetic patients. So
Diabetic
this
patient, other eye I already showed, which Dr. Mariam answered. So if this is the other, what is the diagnosis here?
BDR.
What?
Proliferative diabetic retinopathy.
Do not tell any short form here. Proliferative diabetic retinopathy. Okay. And so you said hyperfluorescence, areas of hyperfluorescence. What are these dot-like hyperfluorescence?
And also
what are these?
These are microaneurysms.
Okay.
And the areas of leakage and the areas and this is new vessels.
Okay.
There are also
new vessel. Okay. What is the location of microaneurysm? Where do microaneurysms stay?
Microaneurysms.
What is the histopathological location of microaneurysm?
Histopathology, yes.
Which layer does it stay? Microaneurysm. What do you see the microaneurysm?
And inner plexiform layer.
Wrong. You'll have to read that. Okay. And how would you manage? How will you manage this case?
How can I'll management?
Yes. Yes.
Management first by controlling the systemic risk factors
when they are saying how do you manage, you just ask them, okay, sir, I would like to ask history and about the duration of disease and what other I showing. I'll examine, like try to give a hint that I'll try like to take history and examine also the examine the other eye. The doctor the examiner wants to go directly to investigation and management. You can go to first investigation and then management. And investigation is also first systemic investigation and then management. Like you have to like fasting blood sugar, postprandial blood sugar, hemoglobin A1C, kidney function tests, lipid profile, blood pressure, etc. and they should be controlled. And then you can do ocular tests. Which ocular test will you do?
I can do OCT delineate the macular edema.
If there is macular edema and this
Yes.
kind of PDR, so which thing will you treat first? Macular edema or PDR?
I'll treat macular edema first because during PRP the edema will increase.
Yes, good. I think your time is over. So basically in exam time will be very less. So try to use the time very judiciously, but you answered very nicely, Dr. Eva. Thank you.
Thank you.
Who will continue next?
Yes, sir, I'll do it, Dr. Temina.
Okay, Dr. Temina. So this is a old lady, 80-year-old lady. She has this kind of feature in both the eyes. So what do you see and what is the diagnosis here?
Right. So this
By 60 in both the eyes. Visual acuity
right.
is by 16 in both the eyes. So 80-year-old lady.
This is a fundus photograph of the right eye, showing extensive scarring of the macula with the pigmentary changes,
What is
as
the
well as
what is the location of the scar? Preretinal, subretinal, intraretinal. What is the location here?
the location of the scar is subretinal because I can see blood vessels traversing over the superior part of the scar.
Okay. So what would be the cause for this scar, both eye?
You said she's an 80-year-old lady.
Yes, 80-year-old lady.
Okay, so this could be scarring secondary to choroidal neovascularization. It could be scarring secondary to age-related macular degeneration.
Okay.
Advanced stages of age-related macular degeneration.
Okay. How can you help her? What can you do for her?
Okay, so I will counsel her that this is an irreversibly damaged eye and that visual acuity cannot be restored. However, I can help her by prescribing and advising her the use of low vision aids so that she can.
Dr. Temena, do not be so pessimistic. So this can be a scar, but you will have to see the OCT. You can
Right.
do a program for that. Though some scars might appear like this disciform scar, but they might have activity. Okay.
Okay.
So
Okay.
if this thing shows subretinal fluid, specifically subretinal fluid or intraretinal fluid, and if angiogram shows choroidal neovascular membrane which is active, you can actually
Right.
offer the VEGF also. So definitely
Right.
before going to that, nothing can. Do not say nothing
Right.
can. Look, this is
Okay.
we cannot want.
Yes.
People come with hope to us. We cannot say
Yes.
that we cannot do anything for that. There can
Yes.
be multiple things. So
Yes.
you investigate the patient. Yes, I'll see
Right.
whether things can be done, and
Yes.
you like definitely do an OCT if necessary. You can do angiogram also, but OCT is a must for this. And then
Yes.
if there is activity, you can give anti-VEGF, and then what you said, low vision aid and
Right. Low vision aid and what else can I give her? I can give her oral supplementation for based on the AREDS2 formula. I can advise her.
okay. Acha, what are the indications of AREDS formula? Can you give it to everybody, or what did the study?
No, no, it is actually for the dry form of age-related macular degeneration, not for the wet form.
No. It can be for wet form also. Patient has two eyes. Patient one eye has wet eye. Wet form
Right.
other eye has this thing. So you'll have to tell that
Yes.
if there is confluent drusen or a large intermediate drusen, or there
Right.
is
Right.
complication. Like you'll have to read about the high risk criteria for ARMD. And also you can, if there is cataract, you can do cataract surgery for this patient. If there is
Yes.
if there is refractive error, you can give refractive correction for this patient. If the patient is smoking, definitely tell them to
Yes.
smoking. Okay.
Yes.
So
Yes.
like in exam, do not say that this is a irreversible damage has been done and I cannot do anything for you.
Yes.
That will be very
Right.
pessimistic, and the patient in practice also you cannot tell like that because
Right.
patient will be very frustrated and they
Yes.
are
Yes.
so old aged people. And
Yes.
read about everything like how you treat CNPM, what are the high risk criteria, high risk characteristics of uh what like how did they define ARMD, what was the indication for AREDS anti-VEGF agents, what are the dosage schedules of anti-VEGF agents,
Right.
etc. Okay, you did good. I'll
Right.
go to the next because in exam time is very less, so we'll stick
Okay.
to the time. Okay, thank you. And
Okay.
Dr. Temin, you did not introduce. Please introduce yourself. Yeah.
Yes. I'm Dr. Temina Jahangiri. I'm working as consultant ophthalmologist in Lahore, Pakistan.
Okay, thank you. Who will volunteer for this next? Please, this is a mock exam. And
Okay, I will volunteer.
okay, Dr. RC, please introduce yourself.
Yeah, I'm Dr. Arshi. I'm working as a comprehensive ophthalmologist in Dubai.
Okay, Dr. RC, this is a 80-year-old male who has both eye finger counting close to face vision and both eye has similar kind of picture. So
Okay.
what do you see and how do you manage this case? 80-year-old male, both eye finger counting sudden onset. 2 days back, he is having this kind of thing, and he's very stressed.
80-year-old male having bilateral or decreased vision all
Yes,
of a sudden.
Hmm.
Sudden decrease of vision. So what I see in the fundus is this is a fundus colored photograph of left eye showing the optic disc and peripapillary crescent. I can see in the macula.
This is not a crescent. This is a papillary like hyper depigmentation all around. Crescent is like a area of like a. So this is not a moon. This is a peripapillary. You can say peripapillary 360 peripapillary depigmentation. Okay, and
Okay. And then in the vessels looks okay. There's a tusslated fundus. The macula shows all around a halo-like appearance with the central hyperpigmented spot. So
okay. So I am saying that this is sudden and both eye has similar feature and patient has finger counting close to face. In like 1 month back he was examined elsewhere and the vision was like 6/6. So what?
actually, I would have gone with the differential diagnosis of if it is sudden vision loss, giant cell arteritis, but I will not go in this because it is bilateral at the same time because it takes at least 2-3 days to go in the other eye.
Okay. So why
And
no, you what is the like what is the finding? Why do you say that this is giant cell arteritis? What in fundus what do you see? In fundus, what do you see?
yeah, in
What is
fundus I
diagnosis
yeah.
here? And did you comment about the disc? Is it current normal or is it abnormal?
No, the disc looks normal, doesn't look pale. But there is a
So what about
the
the
reddish
or
hue of
anything?
the reddish hue and the perifoveal there is retinal edema type of thing like
What is
cloudy
this?
appearance.
What is this?
This
What is the
this
retinal finding here?
this
Diagnosis.
can be this normally happens in the central retinal artery occlusion,
Okay. So
but
basically
it
you will say
doesn't look like
you will say,
overall.
doesn't look like what?
Like overall, the retina is not white.
No.
It's only the
This
perifoveal
is the
area which
issue.
is
This is the
looking.
issue. In CRAO, you can have a central. Basically, the whiteness is usually in the around the fovea or around the disc. In the periphery, the whiteness is not there. So this kind of feature can also be there. This is a central retinal artery occlusion. So time is over. So yes, because both eyes are involved, you have to rule out translateratis here. So that is why I gave this, and you have to do like you have to read how you diagnose giant arteritis when you do arterial tabulatory biopsy. What is the relation with steroid? How long do you treat with steroid? What are the management of CRO? What are the predisposition of CRO? How do you investigate a case with CRO? And how do you immediately manage the patient with CRO? You did good. Just read about it. I'll go to the next candidate. Who anyone who has not volunteered.
I will take any first question.
Dr. Najla, okay. Dr. Najla, this is a 30-year-old male who has this sudden onset of dimness of vision in this eye. What do you see and how do you manage?
It's a fundus picture of
Dr. Najla,
left.
did you introduce yourself? Please introduce.
Yeah, I am Dr. Nijla. I am from India, Kerala. I am working in Kerala in Eye Foundation as a consultant ophthalmologist.
Okay. Please discuss this fundus photo.
So it's a fundus picture of a left eye. The media
Why is
suppose.
it left? Why is it left eye? Dr. Nazla, you will fall in trouble.
Sorry, the right eye.
No, do not. I'll request you, do not say this. If you say left eye, they'll just fail you immediately. Okay? Please
Okay.
take some time to introspect, to analyze, and then speak. Do not speak directly. Do not speak. You can say, you may maybe mute. That is okay. But if you speak, you have to
Yeah.
be correct. Or if you can
Mm.
also say, I do not know. But do not say wrong things, because it will be a negative thing. So which eye is this?
Right eye.
Right eye. Okay. What do you see in the right eye?
Yeah, the media is clear, mostly clear, and I can see the disc margins are blurred, and the vessels are particularly the veins are extremely tortuous. Arteries I couldn't make out in this picture, and I can see the flame-shaped hemorrhage all over all four quadrants, and I can see the cotton wool spots along the vessels, and I can also see the dot and blot hemorrhages also,
Okay.
and
So
macula also appears edematous.
what is your diagnosis here?
Probably a case of CRVO.
Okay. No, do not tell small part. Just tell full part.
Central retinal vein occlusion
In the right eye with
in the right eye, with macular edema and
okay.
disc
So
edema.
how do you investigate?
Yeah, since it's a 30-year-old male, so first I will ask about history about any bleeding or clotting disease he has, or some other medical problem, and diabetes, hypertension. So then I will ask about how long he is having the symptoms. Then I will think about the investigations, like blood investigation first. I will check done do his BP and IOP get checked. Then I will
What?
BP, blood pressure and intraocular pressure should be checked.
Okay.
Then the systemic investigations, mainly I will do the full blood count, CBC and ESR, then CRP. Then mainly in this case,
Why,
the clotting.
why CRP? Why CRP? You will do CRP. Why?
Yeah, maybe some inflammation is there. Some inflammatory causes can be be the cause of
like
Eels disease. I'm not sure. Eels disease can
cause, yes.
vasculitis can cause this.
Can cause vasculitis, like that is more of periphlebitis, like periphlebitis or papillophlebitis or like vasculitis near the eye. But yes, you can do. And any other thing?
And the clotting, like bleeding time, clotting
Will
time,
you do
PTNR.
fasting blood sugar?
Yeah, that is more important.
Yes.
The blood sugar also very important. Then HbA1c if he is already diabetic. Then in clotting, bleeding time, coating time, PTNR, APTT. Then protein C, protein S. Since it's a very young male.
Any other thing?
Then I will do the ophthalmologic investigation, like I will get done OCT macula as soon as possible to see how much is the macular edema. Then I will
I have a, please, any candidate, please, everyone, please show your name, otherwise I'll remove. iPhone, please show your name, or I'll just remove you. Please, this is a professional exam, and we do not want anybody, like any anonymous people here. Dr. Nazla, actually our time is over, but you did good. So basically the reading will be, you have to say homocysteine in CRVO, like young CRVO cases, you have to do homocysteine. You have to read what homocysteine's features are, homocysteinuria's features are, and from homocysteinuria they can go to Marfan syndrome. This in CRVO, you will have to read what are the like causes of CRVO, how do you investigate, like OCT, what can you see on fluorescein angiogram? Can you do fluorescein angiogram in the early phase, and what do you see in fluorescein angiogram late phase? When does glaucoma occur? In glaucoma occurs, what are the causes? How do you manage neovascular glaucoma? How do you treat macular edema associated with this CRVO? What are the features of central venous ocular study, CVOS studies results? Yeah, read about it. And what did they say about macular grit in macular edema due to CRVO? What did they note? Just Dr. Nazla, your homework would be findings or conclusions of the CVOS study. Okay, you did very good.
Okay.
Thank you. Please,
Okay.
but do not say other eye. This is very wrong.
Yeah,
Ah,
I got confused.
yes, no. Take some time. Take some
Yeah.
time. Then only respond. Who will volunteer next?
Dr. Asma Azhar.
Dr. Asma. Okay, please
I'm from
volunteer. Please tell
Pakistan.
your name.
Yeah, Dr. Asma Azhar. I'm from Pakistan, and I'm a general ophthalmologist working here.
So this is a patient who has a recent onset one-day vision loss, 60-year-old male with cataract surgery done 3 years back, and he has yak capsulotomy 1 month back, and now he has this. So what do you see?
Okay, so one month back he has got his cataract surgery done.
Yak capsulotomy in this eye, and now he has this dimness of vision.
Now he has no vision. So, sir, this is a colored fundus photograph, and I can't make out from this which eye is it. But it has been, I can see, however, in the supratemporal, there's a horseshoe tear.
You do not say supratemporal, you say in the upper part of the image, I can see a horseshoe tear. Okay,
And there are in the lower half from like 10 o'clock to 4 o'clock, I can see.
No. Because this is a small like local photo. You cannot say where it is. Okay, it is like you just said in the lower part of the photo. What do you see? In the
Oh,
retina, what do you see?
yeah, there is
You may not be able to tell the degrees because this is not a wide photo and you do not know which eye and
okay,
etc. You can just say what. Basically, do not in exam do not like think that it may be there.
okay,
Just tell what is visible. Do not extrapolate anything.
fine. So, sir, in the lower half, I can see some whitish linear streak-like shadows in the lower half. Along with that, there are certain, and the blood vessels can be seen, which are quite straightening of the vessels I can see there.
So what is the diagnosis here, Dr. Asma?
Uh, yeah, I think because of seeing the horseshoe type tape tears and
No.
the
Look, there are corrugations. No, the retina seems elevated, the vessels are bent, etc. So what is
it it can be the regmatogenous retinal detachment in this eye,
yes,
which is
yes. So this is a rheumatoid retinal detachment. So this happened after yak cap. Is there any causation with? Is there any connection with the yak capsulotomy here?
yes, with the yak capsulotomy, it is possible that there can be a vitreous hemorrhage, and which can lead then to the fibrous proliferation and then the tear and the detachment.
Wrong. Your homework will be how yak capsulotomy predisposes to
Okay.
retinal
I think
detachment.
PVD happens.
Yes.
Vitreous
Vitreous detachment
detachment
happens, and then
happens.
it can cause this. This thing, the
Okay.
vitreous fibrous proliferation, etc. This is wrong. And you'll have, how do you do yak cap, Dr. Asman? If you
How,
yak capsulotomy, how would you do that?
yak capsulotomy?
Yes.
So for the yak capsulotomy, we have to like the yak power.
Which machine will you use? What is the wavelength of that machine? And what is the lasing substance?
What is the we will use the YAG laser. I'm sorry if I couldn't understand what are you asking?
What is the wavelength of the laser? And what is the lasing substance used? Yes.
Wavelength, sir, I'm not sure. I have to read
Okay.
it again.
What is the lasing substance? Laser is produced by a material, no? What is the material? You said an yak cap. So what is yak?
YAG is a it's a photo disruptive.
No. What is the full form of yak?
Okay, it is a yes. This is totally slipped out of my mind. Right.
Okay, just read about
I,
it.
yeah.
What are the settings? Just tell me the settings and then we'll go to the next candidate.
From 1 to 5 millijoules we use in the YAG, and we like in the form we just focus the posterior capsule and then we inject it.
Is there any lens which you can use for your capsulotomy?
Yes, it's a
What is the name of
pan
the pan fundoscopy lens for your capsulotomy?
no, for
Nobody
the
can
YAG.
use. It is not used. Do not say anything which is wrong.
Okay, so I have to read it. I've just forgot.
Please read and post it. Look, this is just a mock exam. I am just testing your, and it is necessary to keep your calm and do not speak anything which is bogus. If you speak wrong, then it is a bad day. You may not, you may be quiet. Okay, sir, I do not know. That is okay. But do not tell something which is grossly wrong.
Yeah, sir, I remember it was Abraham's lens.
Yes, Abraham. What is the A of what is the power of Abraham's lens?
Power is
You have
so
to read that. You have to read that. How you have to read also read how does Abraham lens help in your capsulotomy? What is the power you will use when in relation to cataract surgery? When can you do your capsulotomy? What are the specific patterns described in your capsulotomy? What are the side effects of your capsulotomy? Okay,
Fine.
you post everything in the group. Thank you.
Okay. Thank
We'll
you.
go to the next candidate. Yes, we'll go to the next candidate who will volunteer now. Anyone? Dr. Wafa. Dr. Wafa has joined recently. Please introduce yourself, Dr. Wafa. This is a photo. What do you see in this image?
I am Dr. Wafa Asherman from Jordan. I didn't have a chance to participate in FRCS this round. I'm waiting for November round in Amman.
Okay, it's okay. Just tell us what is the what do you see in this? What is the imaging modality and which eye is this?
Okay, this is an OCT image.
OCT. What is the full form of OCT?
Spectral domain.
No. What is the full form of OCT?
What is what?
Full form of OCT. OCT. What do you mean by OCT?
Optical coherence tomography.
Okay. So what is visible here?
I can see
which eye is this?
right eye.
Okay. And what do you see here?
I can see vitreomacular traction over the macula.
Okay.
Causing.
What is the difference between vitreomacular traction and vitreomacular adhesion?
And vitreomacular what?
Adhesion. What is the difference between vitreomacular traction and vitreomacular adhesion?
Adhesons?
Adhesion, yes. VMA versus VMT. What is the difference?
Traction, it causes irregular contour of the macula or of the foveal contour, while adhesion, it's only over the fovea without causing that irregularity.
Excellent. So what do you see here?
There is a broad band of traction over the fovea with intraretinal cystic spaces and subretinal large cystic space.
Acha. There is there are some white dots in the vitreous, no? What could it be? Can you see in the upper side, in the left side?
Yeah.
This patient has diabetes. Diabetes this patient has, and this patient also complains of floaters. So what could it be? The left side, in the image, in the vitreous also there are dot opacities, no, hyperreflectivities. Can you see? Can you like?
Yes, it is from the pigment epithelial layer.
Diabetes, and he has floaters. So what could it be? This
it could be from pigment epithelial layer. Pigments.
No, why would pigment come in the vitreous?
Okay, it could be a hemorrhage.
Yes,
from the
hemorrhage from
the traction of blood vessels.
From traction of the blood vessels. What is the commonest cause of vitreous hemorrhage in a diabetic? What is the commonest cause of vitreous hemorrhage in a diabetic? So I think we passed the time. You did very good. So you will have to read what are the common causes of vitreous hemorrhage. You will post it in the group. What are the common causes of vitreous hemorrhage? And like how do you manage a case with vitreous hemorrhage and vitreomacular traction in the case of PDR?
Okay.
And the other would be you will have to provide post a chart on showing what are the classifications of like international vitreomacular traction study group. And like what are the OCT classification of diabetic macular edema? Okay, Dr. Wapa, do that.
Okay. Okay. Yeah.
Thank you. Thank you. You did very good. I think we'll go to the next candidate. Who will volunteer? So it was 1064 nanometer. The laser which we use for yak capsulotomy, it is 1064. It's not 532. And the bleeding is from new vessels, like not traction on the vessels. Traction on the vessel can cause bleed in new vessels also, but you'll have to say in proliferative diabetic retinopathy, in diabetic retinopathy, the bleeding is due to proliferative diabetic retinopathy, and the proliferative itself means there is new vessels. Dr. Wafa. Okay. Who will volunteer now? Abhinaya? Dr. Abhinaya? Oh, this is a mock exam, I'm saying again. And Dr. Yasmin, congratulations to you for passing. Dr. Abhinaya, can you please volunteer, or who will volunteer?
I will volunteer.
Yes, sir.
Dr. Abhinaya, please.
Yes,
So
sir.
you can see this. This is what do you see in this image? Which
Yes,
eye?
sir. Uh, this is a OCT picture of the macula.
Okay. Which eye?
And it is the left eye. Where it
Okay. What do you see?
is the left eye, sir. OCT picture of the macula, which shows before the retinal layers for the macula. Probably,
What did you say?
I can see. I can say the differential diagnosis would be lamellar hole.
Okay. No, what is
Because
the surface? What is there in the surface of the retina? Is the surface normal? Is the vitreomacular interface normal? What is there?
there is epiretinal membrane.
Yes. And
I can see the hyperreflective epiretinal membrane and retinal edema is there.
okay. And this kind of vertical edge of the foveal pit and thickening of the inner retina around it. What is it called? What is this appearance called? So
Foveal ring. No,
no,
sir, I'm not.
you'll have to read about OCT classification of ERM, new classification. Okay.
Okay, sir.
How do you differentiate from pseudo hole? Just tell me, how do you clinically differentiate pseudo hole from a full thickness macular hole? Dr. Abhinay, you did not
Yes,
introduce yourself. Why do you practice?
Sir, I'm general ophthalmologist, sir. Currently I'm not practicing, sir. I'm on leave.
Okay. So like how do you differentiate clinically a pseudo hole from
By
a full thickness?
using direct ophthalmoscope, when you see there will be absolute photoma in the macular hole, which is Watsky-Allen sign.
Okay, Watsky-Allen, do you do it direct ophthalmoscope? How usually Watsky-Allen, how do you do?
Sorry, sir, I didn't get it.
How do you do Watsky-Allen test, Dr. Abhinaya?
Sir, by using the direct ophthalmoscope, I will see the patient. I will tell the patient to see straight far away, and by using a direct ophthalmoscope, I will focus on the macular area. So that time,
how will you like prepare the direct ophthalmoscope for this for Watsky-Allen? Is Watsky-Allen what is the textbook picture of this? Textbook description of this? How do you do that? Please read about it, Dr. Wapa. You can do with direct ophthalmoscope with the white like linear streak, but that is not what is written in book. Okay, just please read
Okay,
about it
sir.
and then you have to write. And
Yes,
also,
sir.
like you'll have to read and post in the group what are the differentiating features of pseudo hole and full thickness macular hole.
Yes,
How
sir.
do you differentiate pseudo hole from lamellar macular hole in ERM, and also what is LHEP? Okay,
Last
you
what
read
you
it.
told, sir? What is?
LHEP.
Okay, sir.
I'll go to the next candidate. Who will be volunteering now?
Sir, I need to ask a question, please.
Yes,
How can we know the eye, right or left eye from this picture?
yes. This is there is a near infrared photo, no, in the below picture. There is an infrared photo in the below. Look, there are two pictures. Upper picture is OCT and lower picture is fundus photo, which is a infrared image. And you can see the
Okay.
disc here. You can see the disc here. And
Yes,
also,
I
if
can see it.
you are careful enough, you can see the OS MM6 is selected in the left lower corner. The selected area OS MM6. That is left eye.
Okay.
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 So
Thank you.
if it was a horizontal scan, then how can you tell which eye is this? Dr. Asma, this question is for you. If the
Yes.
scan was horizontal, how do I tell which eye is this?
Horizontal like this in the upper?
No, this is a vertical or this is a vertical or a little tilted scan. I am saying if the scan is horizontal, can you tell which eye is this from seeing the OCT picture alone? This will be your
From the
homework. From the
OCT picture alone?
From the OCT picture alone, if they give you a scan, which is horizontal scan running through the fovea, can you tell which eye is that from the
I
scan
can
alone?
tell by the last layer in the retina. If it's more thicker, it will be to the right. It will be to the right side, near fiber layer.
Okay, yes, correct, excellent. Thank you. So I'll go to the next candidate. Who?
Yes, sir. Dr. Mariam here.
Dr. Mariam. Please introduce yourself.
Sir, I'm Dr. Mariam Sama and I'm working in Karachi, Pakistan as an general ophthalmologist.
Okay, Dr. Mariam, this is the image. This is a 60-year-old male, sudden onset dimness of vision. So this is what is visible here. So what do you see, and what like vision is PA, like hand movement close to face, PR inaccurate. So this eye is not seeing anything. Like this has been there for like 1 month or 2 months. 1 month or like 1 month. And what is visible here?
So this is an optical coherence tomography image of the left eye, and
Yes.
there is absence of foveal depression, or
No,
you can
pelvic
say
is
there
present.
is
Who says there is
there
absence
is
of pelvic present? Well,
sorry,
this
sir, there
yeah.
is sir, there is foveal depression, but throughout there is the atrophy of the retinal layers.
Okay, yes. And
And
what is the change in the retina? Is there any change which you can see?
At the level of the foveal, there is some RPE irregularity also.
No. Is there any change in
Photoreceptor
the
less.
retina? In a retina, do you think there is any change?
Clinical fundus photograph.
No, not fundus photo. In the OCT, in the inner retina, do you think everything is okay, or there is something? There is some, yeah.
There is a thin layer, or we can say ERM, epiretinal membrane.
Okay, retinal membrane can be there. What has happened to the inner retina? Is it correct? Is it normal? The retina is thin, that is correct. Is the inner retina normal, or there is something, some change here? Any candidate. This is a little difficult photo, but I think we must recognize this.
Yes, Sarah, I think it is central retinal artery occlusion.
Yes. So this is the inner retina has become opaque and it is hyperreflective. Yes. So we all like ophthalmologists must recognize the features of CRAO, including its OCT feature. So this is a feature of central retinal artery occlusion because the fovea doesn't have the inner retina. That is why the inner retina is like black. And that is the area where it will say show cherry spot because it will show choroid. But around the fovea, the retina is whitened. It is the inner retina fully is whitened. So that is due to central retinal arterial occlusion. So you'll have to, this is not a normal fundus, normal OCT, and you'll have to know that this is there. And because the central retina is like fovea is not clearer, so you can see some the RP is much more prominent in the center because the light can pass through that. And this is not PAM.
Okay.
PAM, Dr. Heba, I think, answered PAM. Dr. Heba will write, now Dr. Yasmin. Yasmin will post a like difference between PAM and like CRO, features of CRO in OCT. This is not PAM. PAM is a localized area, localized problem in the inner nuclear layer. So this is whole inner retina is like white. Okay. But this was a like little difficult question, but I kept it because you all need to understand that, look, there are many, very few diseases in which we have to act rapidly. Otherwise, the patient might lose vision or might lose their life. So CRO is one of them. In CRO, there can be some like emboli can be there and thrombus can be there. That's why you'll have to do cardiac workup. So it is something, or if it is bilateral CRO, there you'll have to rule out giant cell arteritis. So, and CRO itself is now thought to be a part of the stroke spectrum. So we cannot miss CRO. Okay, so that's why I kept this. Somebody will read about CRO and also post photos of CRO image, OCT images and fundus photo images, and how do we differentiate from what are the features of BRAO also. Okay, and also what are the causes of cherry red spot. Okay, I think we'll go to the next candidate. Who will volunteer? I think somebody has written many questions. Dr. Abdul Rahman Khattab, you have answered many things, but you did not talk. So please talk now. Dr. Abdul, are you there? Okay, I think anyone who is there can volunteer. Who will volunteer? So this is the last year, and then I will close.
I will volunteer, sir.
Dr. Kabir, please introduce yourself, Dr. Kabir.
My name is Dr. Abdul Kabir. I'm working as a general ophthalmologist in Peshawar, Pakistan.
Okay. So Dr. Kabir, this is a person, this is a female, 40-year-old female. She has like 6/12 vision in both eyes. There is some cataract and you see similar feature in both the eyes. So what do you see and what is the diagnosis here?
This is a colored fundus photograph of the left eye. The optic disc and vessel seem normal. And in the macular area, there is a pigmentation inferior temporal to the fovea. What is the age of this patient, sir?
35, 40-year-old. Similar picture in the other eye also. I'll give you a clue. In OC, you do optical coherence tomography, you see some thinning here. The fovea is thin, like the foveal thickness is 190 micron. What is the normal foveal thickness, Dr. Kabir? In OCT, central foveal thickness, what is the normal central foveal thickness?
Normal is about 250 micron.
Okay, so this patient's thickness is 190 microns in both eyes. So how, like, what could it be?
It could
And
be.
there is, I'll say there is some perifoveal halo, like some graying of the area around the fovea. So what could it be? So please, this is macular telangiectasia, typical feature of macular telangiectasia. You'll have to read. This will be homework for Dr. Kabir. What are the features of macular telangiectasia? What are the stages of macular telangiectasia? What are the OCT features? What are the fundus features? Fluorescein angiography features? When do you treat? And how do you treat such cases? Okay. So I think we are already just, this will be a rapid fire. Can anyone tell what is this? Anyone? So I'll close by 7. So this patient is this is like 68-year-old person who has this kind of picture in the
CMV.
This is wet AMD or with the bleeding, intraretinal bleed.
No, you cannot tell bleeding. You cannot say bleeding from OCT. So this you are seeing some subretinal lesion with intraretinal fluid, most likely due to choroidal neovascular membrane. Okay, do not say bleeding because you cannot. You have to see the fundus photo to say whether it is bleeding or not. So you have to say hyperreflective lesion in the subretinal space, most likely, which is most likely a choroidal neovascular membrane, and there is intraretinal fluid or intraretinal cystic spaces in the retina. So what is this?
This
Dr.
is
Bajaj?
pre-retinal hemorrhage.
Retinal artery macroaneurysm.
Retinal artery macroaneurysm. Why is it retinal artery macroaneurysm?
Pre-retinal hemorrhage in the vitreous.
Yes,
Hemiretinal.
there can be pre-retinal hemorrhage, but why is it retinal arterial macroaneurysm? Will it be local area or it will be involving both total area? And there is a OS separate area of involvement. No, the hemorrhages are going temporal to the fovea also.
Hemiretinal vein occlusion.
Yes, so you can say that the differential can include retinal arterial macroaneurysm, but this is the features, the orientation of the blood, etc., are in a OS separate pattern. So this is a BRVO. Just read about this, and I think we finished in time. So if there are any questions, you can post it on the group. Please take this opportunity. Hello, am I audible?
Yes.
Yeah.
Yes. So we actually had previous classes, and I think those are available in this thing. I'll not discuss those here. So thank you, and I think you learned something.
Thank you.
And I'll request. I'll again congratulate Dr. Yasmin for passing, and I'll request all the candidates to please volunteer. Thank you. Good day.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you.